All right. Hello, everyone. We're going to go ahead and get started. I'm Brad. I'll be moderating today. Welcome to CortiCare's webinar on breach rhythms. Your presenter today is Dr. Navita Kaushal. She's been with CortiCare for about 5 years now. She has 10 years of experience in the neurodiagnostic field, as well as 14 years of teaching experience in anatomy and physiology, and 10 years of research experience exploring the effect of sleep deprivation and hypoxia on the progression of neurodegenerative disorders. She's obtained a bachelor's, master's, and PhD, and currently holds credentials in REEGT, RNCST, and NACLTM. She's a wealth of information, and we're very excited to have her here for this webinar. So without further ado, here's Dr. Navita Kaushal. I think you're still muted, Navita.
There
we go.
Hey, everyone. I'm just trying to get the slides on the page here. Start. Okay, that's what I wasn't doing. All right. Hey, everyone. So today we will be talking about breach rhythms. Just a disclosure, every time I was working on the slides, what I'm thinking is burst. I have no idea why I was always thinking burst. It is breach rhythms. So if you ever hear me calling burst, it's not, it's breach. We are talking about breach rhythms. Okay. I don't have anything to disclose. All the samples that I have today, they are from the articles collected using the PubMed search engine, putting the term breach rhythms, EEG, epilepsy, breach rhythms, and things like that. So during this presentation, we are going to talk about what is breach rhythm. What is the etiology, the genesis of breach rhythm? And as EEG techs, what's the best way to recognize them and differentiating them from epileptiform discharges? Because that's one of the biggest challenges that we face when we are looking at the patterns, which look like breach, but are there any epileptic discharges hidden in that? And during the presentation, you have any questions, please feel free to put them in chat. Brad will take care of them. Okay, so what is breach rhythm? The other name for breach rhythm is breach effect. In the early 50s and even before that, when Berger started recording EEGs, many of his EEGs were done on patients with bone defects, with skull defects, okay? And these pattern that they were recording, it looked something like mu. During the same time when they were recording this bone defect patients, they were doing EEG on these patients with skull defects. They kind of coined the term mu. They discovered there is at the central channels, there is mu-like pattern. So mu was also kind of discovered, kind of recognized almost at the same time. So they started calling the breach mu rhythms. Wasn't mu, they weren't very happy with that term. So going back and forth up to until late 1970s, they were using the term, there is breach, right? But nobody came up with the term breach rhythm or breach effect. So 79, Cobb and his associates, they studied more of this pattern, and they came with an idea that, okay, this pattern is not due to any scar tissue of the brain. It's not because of any brain abnormality or brain pathology. It is because of defect in the skull. So the term was coined in 1979, breach rhythm, breach effect. Breach rhythm is a benign EEG pattern. It can be intermittent, it can be continuous. It does have epileptiform kind of a morphology because it is spiky or sharply contoured. Like I said before, this pattern is not due to any abnormality or the pathology of the brain, but it is a focal skull abnormality. Any skull defects, especially after craniotomy or any cranial surgery. So how is it even generated? So we all are expert in 1020. And we know that we prep the skin to get the best signal possible, decreasing the impedance as much as possible, keeping it within the standards by the ACNS guidelines and things like that. So the skull, it gives the most resistance between the cortex and the electrodes, the scalp electrodes we put. It comes from skull. So if you look at the right side of the picture, about 40,000 ohms of resistance, the impedance comes from skull itself. And skull acts as a filter for all the electrical activity that is generating in the brain coming to those scalp electrodes. And while it is doing that, it is going to attenuate the higher frequencies. Now, there is a significant increase in electrical activity if these resistors are absent. So like I said, skull, 40,000 ohms. From dura, the resistance is about 12,000 ohms, and the scalp is 1,000. Only control as EEG techs we have is the scalp, right? So you prep the scalp and you decrease the impedance as much as possible. But what about the other resistors? Since they are there, the signal that we receive on our EEG machine has to be amplified. Okay, so now let's say these resistors are missing, like in craniotomy or any kind of a skull defect. That's going to increase the amplitude of the waveform that you're receiving. It is also going to increase the frequencies of the pattern that you are going to see you're going to record on the EEG, okay? And those patterns will be spiky, sharply contoured waveforms of breach effect or breach rhythm. Burr holes, do they produce breach? Not necessarily if the burr hole is, usually burr hole is smaller than the electrode, our 1020 electrode that we put on, right? They're smaller than that. So burr holes usually do not produce or do not affect the EEG, the signal that is coming from the brain. Here is an example, very textbook example of a breach rhythm. It is at P4C4 combinations here. And you see that there are faster frequency compared to the rest of not just the faster frequencies, but higher amplitude too. And we get so fixated on the phase reversal of the breach rhythms that we start thinking it's abnormal. So here is something to think about. Not every phase reversal is abnormal. We'll talk about what's happening if the voltage is high and if you're seeing phase reversal and if there is a field to differentiate normal versus abnormal rhythms. The EEG features. So you just saw the epoch. We know that it is coming from the skull defect. Maybe a flap is missing or maybe a part of the skull is missing, not a burr hole though, okay? So the EEG, the rhythm is focal, is asymmetrical, and it is a high voltage. The waveform is arc-like, and it has spiky morphology. This rhythm is irregular, okay? It is most prominent over the central and the temporal region. So because it was most prominently recorded at the central, that's why they named it as mu-like rhythm. I'm going to talk about what about temporal region rhythms. The frequencies of the breach is between 6 to 11 hertz. So that means you are seeing theta as well as alpha, but now the breach rhythm also comes in beta range also. So the frequencies are theta, alpha, beta, mu. This rhythm persists during sleep, okay? And during your stage 2 sleep, when you start to have sleep spindles, they will be of very high voltage if the breach rhythm persists during sleep. So we talked about mu-like rhythm because it's coming from the central region. Now, what about the breach that is coming from temporal? That was one of the topic of discussion in the 90s. They were considering it as third mid-temporal alpha-like rhythm. Niedermeyer, they recorded some of the patients with epidural electrodes, and they saw that the temporal part of the brain is producing alpha and mu-like rhythms. That rhythm is not seen with scalp electrodes. but that is seen in patients. It's completely independent of the posterior dominant rhythm. It has nothing to do with the alpha rhythms that is recorded from the occipital lobe. So this activity was seen with epidural electrodes, and it is not seen in when the skull is intact, that the entire skull bone is healthy. However, another neurologist, they saw that this intrinsic alpha-like activity from the temporal lobe was also seen in patients who had cerebrovascular disorders, who had congenital bone thinning. So they're born with thin bone, thin skull bone, and they may have some sort of skull defect after the surgery, the intracranial surgery. And this pattern was reactive to stim, and it is changing with states. So from wake to sleep to wake, this pattern was reactive. However, its significance was not clear. Is it normal? Is it abnormal? Nothing was known about that, right? So they kind of named it as third mid-temporal alpha-like rhythm, like seen with subdural electrodes and seen in patients who had crani in the temporal region. So that's how we know that most of our breech rhythms are coming from the central and the temporal regions. Okay, so we have the first poll question based on what we talked and what we are going to talk and what your assumptions are, what you think of it. So, Brad, if you could please.
I'm just going to give it a couple more seconds and then I'm going to close it. All right, it is closed.
Okay, so 77% of you say that breech rhythm is normal, and about 15% are saying that it is not normal. So we are classifying it as abnormal. And half of that population, 7%, are saying they're unsure of it. So breech rhythm is a background. It is a normal rhythm. Like I mentioned earlier, this rhythm is appearing not due to any pathology of the brain. The neuronal tissue is not unhealthy producing this. It's the scalp, the bone, flap is removed, and because the resistors are not there, the impedance from the brain to the electrodes is less. That's why you are seeing this pattern. Right. So yes, it is a normal rhythm. So here are some of the examples to see breech rhythm in beta frequency. I know it's a little fuzzy here. So it is the right frontocentral area. You see the faster frequencies breech rhythms. In alpha, on the top left frontocentral. So if you see there is an artifact here which is very rhythmic. That artifact you would see when patient's flap is missing, and it is the movement of the brain, usually with pulsation of the artery or the pulsation of the brain due to flow of cerebrospinal fluid. So here you are seeing this kind of phase reversal kind of an artifact here. That's the movement of the neural tissue. And the breech is in alpha frequencies. Another example here in the central region, the breech it's not continuous, but you see that it is in mu frequencies. And in the last epoch, you see the breech is in beta frequencies. And this can be easily confused with theta slowing in the patient on the left side, but this is a breech rhythm. So how would you know if it is a breech or if it is it's slowing in the patient? That's when you read the history, you get the history, you palpate the skull to make sure that patient did not undergo any surgery or patient did not have any history of a sort that could produce breech rhythms. Okay. The second poll question here, you have this an epoch of 15 seconds or so. Choose the best option which describes this pattern, please.
I'll be closing the poll in just a few seconds. And it's closed.
Okay, let's look at that. Okay, we have a perfect split here. 42% of the participants are calling it awake asymmetric alpha beta, and 57 are calling right temporal breach. So this image is taken from a YouTube video which explains breach rhythm. When you look at something this asymmetric, follow the 50% rule, the 50% of the voltage, right? So until it reaches 50%, you can say that, okay, we are still considering it within the normal limits, right? So I don't have the way to measure the voltage here, but if you visualize it, or if you have a device at home with you, if you see, we have quite a difference, more than 50%. So there is no right or wrong answer for now. Before we jump into conclusion, when we are recording, monitoring, or we are reporting it, we have to make sure that we know patient's history before saying that patient is having attenuation on one hemisphere. So according to the source I took this is a breach rhythm at the right frontotemporal. Okay, all right. We have another question before we move on to the next section here.
Just a few more seconds. And it's closed.
Okay. Here also we have a perfect split, 42% right temporal slowing and 57 right temporal breach. I think it's exactly the same what we had in the previous poll. Again, there is no right and wrong answer. I'm going to go back to the source. I'm sure everybody has gone to this website, eegatlasonline.com. I have taken the rest of the part of this source. This is under the section breach rhythm. So if you have never been to this particular website, go ahead and you can get the confirmation. This is right temporal breach in delta theta frequencies. So that means there is something going on underneath. Maybe there is swelling, maybe there was a bleed, okay, which is interfering with us seeing the faster rhythms in this patient. So again, there was no right and wrong answer here. There is no history provided to you. So both are equally right. So the importance of history, importance of knowing what you're looking at before you make a decision. Right. So what are other conditions apart from skull deformity or craniotomy? Where do we see breach? Okay, there is osteolytic bone metastasis of the skull. So we know that the skull is getting deformed because of the metastasis situation there. And then another one is multiple myeloma skull lesion. So there are a few more things other than doing the craniotomy or missing the flap. We can still see breech rhythms. So what's the significance? What's the significance of breech rhythm? Mostly, breech rhythm is normal. We have seen that it is appearing in wide range of frequencies. Of course, delta is abnormal. We're not saying that when delta is there, it's a normal thing, okay? So theta, alpha, beta ranges. And breech rhythms, when you see with polymorphic delta activity, you have to suspect there is some sort of a brain damage in the patient. If you're seeing that your breech, the pattern that you're seeing is in mu frequencies coming in the central region, ask the patient to move the head. It's just like any other mu that you would see if the patient's bone is intact, the skull bone is intact. So this will be blocked by physical movement, just as contralateral movement of the extremity. Okay, now if it is coming on the temporal region, physical movement will not change the pattern, but any change in state or any stim may interfere or will change those rhythms. The breech rhythm, it is occurring when the patient is awake, when the patient is asleep. The only difference between wake and sleep breech rhythm is the EMG. As soon as the patient falls asleep, the EMG goes away. EMG is again faster frequencies, higher voltage than the background, right? So when that disappears, now you're seeing clear, beautiful, uninterrupted, artifact-free breech rhythm. And as soon as the patient enters stage 2 sleep, the sleep spindle's voltage will be higher than the other side of the brain. Okay, I'm going to tell you a little story about this one. So when I was, I'm sure most of you have read this book, right? Have read either in school or when you were taking your boards. So when I read this book about where the section with the eye blinks and the eye movements and understanding that in perspective to EEG and the questions that we get in EEG board, there was this statement there that shunting of eye potential through the skull. I did not understand that. Believe me, I did not understand that for many, many years. Sadly, I don't have an EEG to show you. So what this whole idea here to show this slide to you is that we know that the eye potentials are so much bigger than the brain waves, right? Than the EEG, as this, you can see this picture here. So what if the patient is missing a frontal flap? So whatever side the flap is missing, the eye blinks will be of smaller voltage, of short. They're shorter than the other side. So the reason being, so I understood this line maybe a year or two ago because there was a question in CLTM somewhere, right? Okay, so this is because the virtue of shunting of eye potential through the skull. The reason we see this big eye blinks is because the Bell phenomena and the potentials from the eye, the eyelid, the retina, everything, it is transmitting through the bone. So our FB1, FB2, or F7, F8, wherever we are seeing those eye potentials, now if the flap is missing, you're not going to see a big eye blink. It's just the lighter side of this presentation. I'm like, it makes so much sense now. Sadly, I do not have any EEG to show you how the eye blinks get affected when a flap is missing. So that would be my next end list to collect. Okay. What is ACNS guidelines on terminology talk about breech rhythm? It is a background. Breech rhythm is a background. So there are 10 sections under the background. One of that is breech rhythm is mentioned as breech effect. So when you are reporting either you're writing your technical report or you're monitoring and reporting to the parent, to the reader, whatever role you are in, you're going to mention if the breach effect is present or absent, or if it is unclear. Again, this is exactly from the ACNS guidelines. So breach effect refers to the EEG activity over or nearby a skull defect. Consists of activity of higher amplitude and increased sharpness, primarily of faster frequencies, compared with the rest of the brain, especially compared with the homologous region on the opposite side of the head. So you are comparing one part of the EEG, one part of the brain EEG signal with the opposite side. So if you're seeing there is a more than 50% difference, you have to start investigating if it is breech rhythm or if it is some other reason, maybe electrode artifact and all those things, and you're going to report it based on that. This image is from the ACNS guidelines. I think my video is coming on D, so it says breech rhythm at C3.
A few more seconds. It's closed.
Okay, all right. So yes, almost all of you got it right. There is a breech rhythm at C3. So if you see, it is higher voltage, faster frequencies at C3 combinations. And like I said, this is from the ACNS guidelines. This is what the answer is. So breech left parasagittal maximal at C3. Okay, all right. So breech rhythms during sleep. So like it was mentioned earlier, we are seeing them both during wake and sleep. Sometimes it's hard to figure out what we are looking at when the patient is awake, moving, walking, talking. Is it breech? Okay. So sleep recording can help. Patient resting, closing eyes, not moving, not having EMG. It can help to differentiate not just the breech from regular alpha, but also if there is any epileptiform activity. The reason being, we know that most of the IIDs, interictal discharges, appear during non-REM sleep, the transition from wake to sleep and during non-REM sleep. And they are not there during REM sleep. So if the breech rhythm is due to the underlying rhythms, okay, it may attenuate or it will completely disappear during drowsiness and sleep. But let's say the breech rhythm is mixed with mid-temporal or alpha-like rhythms, it is going to persist during drowsiness and during non-REM sleep. And again, since you're not seeing EMG and the patient is resting, patient is transitioning to another state, that's when you will have the higher probability of seeing interictal discharges. So sleep recording is must in patients that we see in outpatient lab or even during EMU. All right, another poll question here.
Just a few more seconds. And the poll is closed.
Okay. So when you answer any question, you should read it very carefully, right? What is the usual breach rhythm frequency range? We did talk about that the breach can come in alpha, theta, beta, delta, all ranges. So the usual breach rhythm that you're considering a normal background, it's 6 to 11 hertz. So 85% of you got it right. So to recognize breach, do we need to change filters? Are we even changing filters? Are they going to help us? You have to be very careful if you decide to change filters, because they're going to reduce two high frequencies, okay? So let's say you change the high frequency filter, right? So it will filter out all the higher frequencies of the breach rhythm, okay? And what is left out, it will be more spiky and more sharp waves, okay? Now let's say you want to filter out the EMG to see if it is breach or it is just EMG. Okay, if you're going to change the filters, then you're going to attenuate the signal. And then you can confuse epileptiform abnormalities with breach rhythm. So it's a little bit of a confusing thing. It depends a lot on your background, on how much expertise you hold, how much support you can get from your coworkers and from the reader. So before playing with the filters, there are so many other things that you can go over before you decide to change the filters. And we're going to go over on that in a couple of minutes. Okay. So are we seeing breach only with skull defects? We did talk about a couple of things before, right? So, okay. So now, like so before we talked about the breach can be seen even when there is no skull defect or there is no craniotomy, right? Now, there are few conditions where there is a skull defect or a missing flap, but we are not seeing breach. One is the hemorrhagic stroke. Is because if there is stroke, then for the blood clot extraction, they might have taken the flap out, but now the brain, there might be swelling in the brain, and you're not seeing the faster frequencies, you're not seeing higher voltage, rather you're seeing polymorphic delta there. Then hydrocephalus. All the cerebrospinal fluid is blocking the signal to come from the brain to your electrodes, okay? Tumor is another condition where even if after the tumor resection, if the flap is taken out, the tumor, part of the tumor or tumor is taken out, there may or may not be breach due to, again, swelling of the brain. So the brain health, the state of the brain tissue also defines whether you would be seeing breach rhythms or not. Okay, one more poll question, then I think for a couple of slides there are no questions.
Just a few more seconds. And the poll is closed.
Okay, so 84% are saying yes, 12% are saying no. During the previous slide, I mentioned it is the brain tissue state that can even call the shots if you're going to see any abnormal pattern. Like polymorphic delta, you would see if there is any injury to the brain, like hydrocephalus, or there was a hemorrhagic stroke, right? So same thing. The answer to this is yes, breach can be associated with interictal discharges and other focal abnormalities. So in this paper, it's beautifully written that a skull defect provides a true window of opportunity to examine the EEG signal close to its source. So if the flap is missing, now the brain is not exposed to the elements, but you have a better connection. Your 10/20 has better connection with the brain. So I'm going to use that to the best of our ability to understand what's going on underneath that. We're going to switch gears. We're talking the normal, little bit of abnormal, but now let's talk ictal and interictal patterns with breach. Okay. So there is this paper, Disappearance of Breach Rhythm with Tumor Progression. So in this case, this 52-year-old patient was presented with recurrent partial seizures, olfactory hallucinations. So MRI revealed that there is an intracranial tumor on the right frontal and the temporal lobe, and it has infiltrated the basal ganglia too. Okay, the patient had crani, and patient developed generalized tonic-clonic seizures. Patient was put on anti-epileptic regimen, and the seizures were reduced to partial, but still patient had olfactory hallucinations and sensations of epigastric rising. So because the tumor is on the frontal as well as temporal and the basal ganglia area. All right, so what's happening here? In this patient, after the crani and the partial removal of the tumor, we see breach. The patient, it is a 14 Hertz breach rhythm 5 months after the craniotomy. So in this paper, there are multiple images which are taken at different time points. The patient's tumor grew and they had to do second crani to remove part of the tumor again. Again, it's a partial remover. They cannot remove it full because it was closer to eloquent cortex. And 16 months after the craniotomy, the second craniotomy, 16 months after this, patient still showing breach since the tumor was removed. And 23 months after the second craniotomy, the patient's tumor came back, the tumor was growing. And if you look at this EEG epoch, the breach rhythm disappeared. So the tumor progression made the breach rhythm abate. So it means the tissue is not healing, the tissue is inflamed, tissue is sick, and we are not seeing, and there is loss of faster frequencies, which we would usually see in breach. So breach and brain tissue health or brain tissue state, right? So the functional state of the underlying brain tissue is highly correlated to the breach rhythms that we are going to see on our EEGs. A patient who was having epileptic events after the crani, they could see subclinical seizures in this, okay? And the breach rhythm was not seen. It was seen only after the seizures were controlled. So let's look at the EEG from this paper. Okay, so this group, they kind of came to a conclusion that breach rhythm could be suppressed due to thoughts paralysis or post-seizure subclinical activity. So here are two pictures. 84-year-old woman presented with fluctuating moderate hemiparesis on the right side. The CT angio was negative for stroke. MRI did not reveal any ischemic strokes, but the patient had an old lesion in the left parieto-occipital region, and they had removed an abscess 14 months ago. And if you look at this, the patient had, so it's only one epoch here. So there is a seizure, an epileptic event here with 2-second break in between. There is no before and after of this epoch. So there is a clear left-sided electrographic event here, epileptic event. And once the patient was put on anti-epileptic meds, the seizures went away. And that's when you are clearly seeing a breech rhythm. So breech rhythm can be masked by epileptic activity. So what do the breech rhythms look like when the patient is having seizures or when the patients are prone to having seizures? First of all, the breech rhythm has absolutely no correlation to produce epileptic activity, okay? But if there are epileptiform discharges in the breech, okay, the risk for seizure increases. If there are sporadic epileptiform discharges, the risk of seizure increases by 4%. And if the breech is in theta range with epileptiform discharges, so theta frequencies breech with sporadic epileptiform discharges, the chances of seizure increase over 3 times. So if you are seeing breech, a normal background breech, absence of epileptiform discharges, the chances of seizures is minimal to none, basically, none to minimal, I should say. But if you're seeing sporadic epileptiform discharges in your breech rhythm, the chances of having cortical epileptic events increases between 3 to 4 folds. Well, let's look at some of these images here from this paper. Okay, before that. So how are we? It's hard. It's difficult, right? Because one, we have higher voltage. We have faster frequencies. Then there's so much of phase reversal happening. And it is focal. It's hard to figure out if there are epileptiform discharges present, right? The morphology of the breech, it is spiky. There are sharps, and then of course you have some electrode artifacts. How would you differentiate electrode artifact and breech and interictal discharges? So this group, Mader et al., they talked about using 10-10 electrode system to minimize the artifact. Where the breech is and where you're suspecting any sort of interictal discharges or any epileptic activity, they suggested to use 10-10 electrode system near the patient's skull defect area. And another suggestion was MEG is not affected. Okay, MEG is not affected by the skull deformity or due to craniotomy. So breech will appear less with MEG. So not all labs have that opportunity to correlate 10-20 with MEG. So these are the two things suggested by this group of epileptologists. Okay. So the best thing is to obtain the surgical history, which is relative to patient's skull and brain trauma, if there is any, okay? It's easy to miss the skull defects, especially when the flap is replaced either with the same bone, the skull bone, or some sort of an acrylic material. So if you palpate, you may not even know that it is there once was missing flap on the patient, right? It's easy when these discharges, they appear in serial trains, right? Individual, sporadic, they're hard to recognize, okay? And when you have this single spike-like waveform, you're always thinking, is it electrode pop, or is it just the breech, or is it even epileptiform activity, right? So the most I rely on is to look at a slow wave after the sharp or the spike. Okay, if there is no slow wave after that spiky appearance morphology that I'm seeing in my quote unquote breech patterns, breech rhythms, I'm going to say that's not epileptic. But if there is a slow wave, the chances of that particular pattern is higher to be epileptic. Now, there is no spread of suspicious activity to other areas. So you're going to see it focal, right? So the epileptiform discharges are going to be focal. So you're not seeing it spreading all over the place. Again, you're going to check if the patient's EEG is reactive. Okay. And please do not rely heavily on phase reversal. Okay. See here, just I wrote burst suppression here. It's not burst suppression, it's breach rhythm. So phase reversals are not indicative of epileptiform activity. And of course, recognizing spikes, polyspikes, spike and wave, also all the entire range of epileptiform discharges, recognizing what their frequency can be, what their amplitude is, what their morphology is helpful in delineating them from the breach rhythms. So here are some of the case studies. So in this, this is a patient that had a large right frontocentral crani and is missing frontal bone flap on the right side. So this on the left, it looks very much like electrode pop. The flap is missing, the brain is pulsating, the electrodes are not sticking, so there is so much going on. And then what they did was in this area on the right side, they did 10-10 electrode placement. And so if you see, you can clearly see epileptiform discharges focused on the right side. All right, patient number 2. So here in this patient here, in the second patient, I just need a cheat sheet here. Okay, so this patient has residual holes in the frontal area from the meningioma resection surgery. Okay, and EEG showed epileptiform spikes in T3, what is it? I'm sorry, T3 and F7. And so again, to verify it, so there is a clear breach on this, and then they have done the 10-10, and you can see clear epileptiform discharges in this patient. Okay, all right. Case number 3. So whether it is electrode artifact or it's interictal discharge due to skull defect. So in this patient here, patient had a large right frontotemporal craniotomy with bone flap in place. It shows intermittent F4 potentials with epileptiform morphology, but there is no physiological field to it. Okay, it wasn't enough to rule out if it is an artifact or if it is an interictal discharges. Okay, so then they added 10-10 electrodes, and if you see here, the patient is not just having epileptiform discharges on the right. Oh, sorry. In this case, they did not need 10-10. My bad. They did not need 10-10. So the patient developed very clear epileptiform discharges, clear buildup, and then an epileptic event. So yes, your breach can produce epileptic events. Again, it's coming from the brain at that time because of whatever the brain pathology was causing it. A normal breach comes due to the skull defect. So here are a few examples of breach rhythm with sporadic epileptiform abnormality on the left side. And then I have one more here. It shows breach on the right with faster frequencies, spiky, sharply contoured, and there is a clear phase reversal with a slow wave after going slow wave, and that is your epileptiform discharge. So as an EEG tech, what can we do? How can we recognize if it is breach, and if that breach is admixed with, is it an artifact, or it is interictal discharges, right? So the very first thing is be thorough with the history. Get patient's history. That is the thing for you to understand the pattern you're looking at. You can correlate it with the history. Palpate the skull if possible. Again, in some cases that may not work because the patient may have the flap being put back. If it is not the original, it could be an acrylic flap. again, we have to go back to the history. Reprepping the skin, adding extra electrodes that we saw in 2 of the case studies. Be careful when you change the sensitivity and the filters. That is helpful, but you have to have some understanding how the filters and the sensitivity is going to change the morphology of your EEG. Test the reactivity. So we talked about how breach is reactive based on what part of the brain you're recording it from, right? And if there is an option in your lab to do MEG on the patient, you correlate with that. And of course, pattern recognition is another major thing that we have to be thorough with. The comfort level has to be the highest when it comes to pattern recognition. So basically, the history and pattern recognition are 2 most important things for you to decide, for you to figure out, for you to say with utmost clarity that yes, this is breach rhythm with interictal discharges, or this is breach rhythm with artifact. So I have one example here with the poll question. So this is a patient with left-sided breach. So what steps would you take to confirm presence or absence of interictal discharges in this pattern?
Yeah, I missed this one, so everyone's just going to have to type their answer in the chat. Sorry.
Right. I'm going to go to the chat window. Tell me when to stop, Brad.
Yeah, whenever you want. Yeah.
Okay. All right. So most of you said C, and I really appreciate that that thing in text that we are ready to go back, open the review, change the settings to make sure what we are seeing, are we really seeing it, right? So I see somebody wrote B. I think once you have this, there is slowing, there is an after slowing of those sharply contoured spiky things. I think you need to investigate. Okay, and I saw 2 or 3 people wrote A. I'm sure you are in the field for so long, and you can just say, "Oh, this is breach with interictal discharges." And yes, I would change the gain. I will change the sensitivity to make sure what I'm seeing, am I really seeing it, right? So let's look at, so this is, and then the previous one was, I think, at 14 microvolts, and this is a sensitivity at 50 microvolts, 50. So if you see that, you clearly see spike and wave discharges. I mean, you lose some, you gain some, right? So now the voltage has gone down and all your sharply contoured things have gone. We are seeing there's delta frequencies, so it means something is going on more than just the breach. So there is a polymorphic delta, there are faster frequencies, there are spike wave discharges. So do not hesitate to investigate. Go back, open the review and see, are you seeing sporadic discharges? Are you seeing continuous discharges? Just do not rely heavily on phase reversal. In breach, you are going to see phase reversals because it is high voltage. Your top and bottom channel are going to touch each other, right? The signal will touch each other. So the best thing is, if you can change some of the instrumentation settings, do it. Of course, we cannot do it on a live recording. Go back in the review, do it, investigate, and then make an educated decision. No guessing in EEG. Okay. So Covitel said breech rhythm, even when very spike-like, appears to have little relationship to epilepsy and is not an indicator of a recurrence of tumor. So like I said before, if you're seeing breech, okay, it's a normal background. Now, breech with epileptiform discharges is a different story. Seeing breech on a patient doesn't mean patient is going to have epileptic events. Patient is going to seize. No, it does not. Okay, and when would it happen? If you start to see sporadically some interictal discharges, some spike and wave are happening, then I think it is something to keep an eye on to make sure that we do not miss that. So that's why be confident. Pattern recognition is the best thing, but expect everything, right? A patient, when we are doing EEG, when we're monitoring EEG, no matter how normal it is, always have in mind the patient can seize at any time, right? I think that's my last slide, and thank you for being here. If there are any questions, I know I made it 2 o'clock, 1 hour. If there are any questions, please go ahead and put them in the chat and we'll take it. Okay, thank you, everyone. Okay, so Ronnie Jackson is asking a question, Brad. I'm going to take that. Can you briefly explain why behind the reduced amplitude with eye closing with missing brain flap? So it's not the eye closing, it's the eye blinking artifact that we see in EEG. That is higher, that is larger than the brain waves, right? Your eye blinks. And it propagates through skull. It has nothing to do with the potentials from the eye are not going into the brain and then you're recording. No, it is propagating through the skull. And when the flap is missing, a patient who has frontal breach will have low voltage eye blinks. Okay, I hope I explained it okay. Okay. Susan is asking, can breech rhythm be symmetrical and asymmetrical? Usually asymmetrical, but if the patient, usually asymmetrical, I would say you cannot have, I haven't had a patient where they have like symmetrical missing bone flaps. So I mean, never say never, right? You never know. So 99.99%, yes, it is going to be asymmetrical. Okay, everyone. Thanks, Brad.
Thanks everyone for being here.